Open it.
It says diffuse calcific bifurcation lesions. Let's see what you got.
Okay, so here we are, live case number 3, myself, and I have Joe Sweeney, who is going to be helping me along with the Yash, who is our interventional fellow, and Tosib. So 83-year-old male who actually has a risk factor with hypertension, hyperlipidemia. He has a pre-op surgery. So because of that, they did a CCTA. So like I mentioned, I think people are moving away from stress test. Everybody gets a CCTA despite him having prior PCIs. They went for a CCTA. So this was done way back in February. If you see that, 3-vessel disease with high calcium score of 3,500 with EF of 60. Then cath revealed that he had a calcific right coronary artery and LAD diagonal bifurcation. So he did a syntax score was 23. We did RCA PCI. We can show you the slide of the RCA PCI. Keep moving to the next slide. So here we are today for the LAD diagonal, calcific LAD diagonal, which I'm going to show you the angiogram. And then his medication you've seen, aspirin, clopidogrel, aterostatin. So if LDL was 121 with the CRP of around 3, serum creatinine is okay, 0.3. So this is where we are with the EF is good, EDP was normal. This is the right coronary artery. He got Zines and circ is okay. Maybe my less than 30 distal left main, but this is where we are.
Oh, okay.
With this, yeah.
I see lots of calcification. I don't know about the lesion, but certainly lots of calcification. We have a wonderful panelist here. Who wants to start? Do you, before we go anywhere, this is a bifurcation lesion, looks calcific. I know Dr. Kinney could fix this in about 15 minutes, but let's see what other people are thinking about. Let's start with you, Sunil, because we haven't heard from you. We have Sunil Rao here. You image first, then you go. What do you do? Take us through your what you think, how you think we should approach this.
Yeah, I mean, obviously this is a very complex bifurcation. Like some of the conversation this morning, it's likely that there's a calcified nodule there in the LAD. I think it's always nice to try an image first just to see if you can decide on your prep strategy. I think the challenge here may be to just get the imaging catheter to go into the LAD. It's just that around that boulder that's there might be a little bit challenging. So, I'd wire both the diagonal and the LAD and then try to pre-dilate and put past the imaging catheter. The ejection fraction I heard was normal, so I think, we tend to check LV EDPs before all of these cases anyway. If it's reasonable with the normal ejection fraction, you can probably get away without having to use any kind of mechanical support. The challenge, of course, is wiring the LAD here. The wire may continue to deflect into the diagonal, but, well, here you go. Not an issue for Dr. Kinney, of course.
And then, of course, the other big question here is the strategy of the stenting. Do you think about that before you even start imaging? You're seeing both of these major branches involved. It's really a 1-1-1, if you will. Is this just a two-stent strategy, so you're really going to have to wire both, probably image both, and think about that? You want to tell us that? Who wants to take that? Yeah, Dr. Chandra.
Yeah, so basically this is, a very interesting and very difficult case, certainly for sure, because it is a bifurcation with a dominant diagonal. This is a big diagonal, and that is the only diagonal which the patient has. So we have to respect this diagonal all the way. And so I will certainly go this way that, as Dr. Rao mentioned, that we do have to do some imaging here to assess the amount of calcification and then decide what kind of decalcification strategy we are going to use, whether we do a rota or we do a shockwave. Both options are available. And then also try to treat it with maybe, I will say, probably either a two-stent strategy. But in India, many times what I do is, after the decalcification, I do a stent to the main artery, and if there is no dissection, DEB to the side branch. That's.
Can you show us how she passes through with
check?
that
Okay.
catheter? I didn't see if she passed.
Okay.
Did
Can I
you
start from here?
pre-dilate, Dr. Kinney, or did you just go with
No.
the imaging?
No, this was IVUS catheter would not
This is
make
the
a
imaging,
turn. And the way that I was having trouble, if you see the angiogram, let me go back
Can
to
you
the
put the
angiogram. Why I
angio
would
on,
not
please? We are just seeing
Yeah.
IVUS. Yeah, thank you.
Good. Okay. So if you see the angiogram here, look at the 90-degree. Okay. So
Yeah.
I actually had the rota bar ready to go rota, but then since everybody said IVUS, so I tried, let's at least try, would not go. Yeah. So of course it's on the rota wire. You may tell me go with another wire, but the way it was difficult to wire, also you saw that I already called. So this was not an easy wiring. This is a fielder wire. I already actually called for supercross, thinking that it may not go. Like Sunil mentioned, it kept going to the diag, but it was able to navigate into the LED. So it goes to the septal, then you bring your fine cross all the way. This is a case where you would want to have microcatheter, some kind of your, filter wire, whisper wire, whatever, the polymer jacketed wires to wire and then change to rota. The strategy what we follow is then if the microcatheter crosses, which it did, then you can go with 1.5 bar. But look at that angle of that LED.
Yeah.
That's a little concerning, still downgraded. So if you see the first case we did, it was a short lesion and became aggressive, went to a bar. But here with this angle, we got to be very cautious, and then of course I would go with the 1.2 for downgraded with the 1.25 bar just because of that. So we are otherwise ready to bar, and I agree with the pan. Now, can we do pre-dilation IVUS and then do it? I think the artery is already telling us that this is very difficult. So just go with some kind of atherectomy.
I agree with you, Dr.
Atherectomy.
I agree with you, Dr. Keeney. I mean, I look at this and I don't even think about IVUS first. I mean, there's just too much calcium, too much angulation. There's going to be too much frustration trying to get down there. I don't think you need any additional information other than the angiogram right now to tell you that this is going to need atherectomy. Share your concern about this extreme wire bias and downsizing the burr.
Yes.
I mean, this is not going to look pretty after the burr goes through that, just because of the bias. You're going to have almost like a double lumen there. But it will break it up enough to allow for delivery of other devices.
I need a run through wire.
This is really very, very interesting. I mean, often with an angulation like this, then that's an extra support wire, or is this a floppy?
It's a floppy. If I take an extra support wire, I think like John LaSala mentioned, I think your wire bias will be
Wire
worse
bias.
if I use it.
Really important point here.
Wire bias and the risk of perforation will be higher. But here you see that I'm not able to even get this across. So very simple. Do your 3 steps, and
Tell us your 3 steps.
on the dyna.
Don't assume we know your 3 steps.
Okay, so here we are. If you see here, your knob. So your knob backward, forward, any tension between the Teflon sheath and the burr is removed. Then at the Y connector, go backward, forward, any tension between the burr and the wire is gone. And the last one, you have the dyna. On the dyna, do a little tap. So hopefully it will not jump. Yeah, it did not. So now it is not going forward. So you see here, this is about 9 centimeters. So you have that much space. What I will do is go forward on dyna. So if you have to do that, you go on dyna, do brake release. Joe is going to do brake release, and this knob is tight, and I'm going to go forward on the dyna. Go.
This is the same trick you would use if you were a single operator trying to bring the burr up.
Yes.
So you see this trick. This is really, really important trick here. The 3 steps, and then using dyna to go forward.
So dyna is really important if you have to go to distal RCA, bifurcating and PDA, AV continuation, distal LED, because your 9 centimeter, you're not going to reach there at that time. So here is okay, but I just wanted to show you the steps. So we're going to start burring off dyna and slow pecking motion. You see that? This is very critical, pecking motion. How my fingers are moving backward, forward. Don't come back too much, because atherectomy only happens with the forward movement. Unlike orbital atherectomy, where your atherectomy happens as you're going backward and forward. So this is only in the forward motion.
So just
we
for the
call it
audience
sneak
to get
and
it,
Also, with
Dr.
these
Keeney.
small burrs, you don't want to get stuck. Sometimes you go past it and can't come back. And you see what she's doing, very slow pecking motion, going forward, slowly and slowly.
It's a sneak
You
and
can see
attack.
how it's,
That's
you can see how it
technique.
sticks
Go ahead,
coming
Ron,
back.
what were you saying? Sorry, I
No,
didn't mean to.
it's called sneak and attack.
Oh, yeah, sneak and attack. Okay, there we go.
I mean,
Attack
for the
calcium.
audience too, though, I'm sure Dr. Keeney's all prepared for the worst-case scenarios, and that is that you have a balloon ready, the right size for this, to tamp on anything, should that be required, and your several wires are ready to protect the side branch as well as to put a more supportive wire down the LED.
With field aware.
I want to do one more polishing run because you see that it's still not smooth. I see little roughed up.
You
So
feel
this is
it, you can feel it. And
Yes,
what,
yes.
the little cloud I see up front before in there, that was, I think, there before, but I think,
Yeah,
this is
that
the
was there before.
calcium.
That was
Now,
there
now you
before.
see,
That's just
now it's
calcium.
smooth.
now much smoother, yeah, we see it.
Yes. So
It's a
we'll come up
125 or
and I have my
15?
run through.
This is 1.25, so the smallest burr.
So Dr. Kinney, this is a large vessel. Why don't you start with the 1.5 here?
Because of the angle.
I think it was the angulation. She explained what she
Yes.
was concerned about,
For
the
perforation.
risk of perforation. It was such a huge 90-degree angle, and in the main, and with the diagonal and the LAD. I think that was a smart move. I like bigger burrs too, and I'm certain she's going to have to go a
So
little
the
bit
question would be if she's going to escalate now to
bigger.
1.5.
Yeah, that's right.
Or you do the whole procedure with
That
one
is
burr.
for the discussion. Let's take a picture quickly and see what we have created. Picture, ready?
All right.
Okay.
You made
Not
very
bad.
good.
Field
That's,
aware.
that's what's
So
called
this
the
is
good.
what the discussion is. Yeah.
And look, take a
Yes,
look at
John?
that diagonal. It definitely, there was some plaque shift into the diagonal. And I think that is also another smart reason to be with a smaller burr, to make sure that you don't close off that huge side branch. And now, I don't know,
Now
it
the
would be good
discussion
to
is,
hear.
do we go bigger bar or do we image and consider IVL?
Yeah, I
But
think
remember
that
there's a
was
side branch also.
that was a little guttering because of the nodule, because of your wire bias. So the lumen actually you got is much larger now. So I think
Yeah, I agree with this.
I would sort of not size up anymore. I would, if you want to image, you can image, and then I would go with.
I'm with
So
Jazz
that's,
here.
that's an important point.
I'm with Jazz here. What about you, John?
Yeah, that's an important point to reemphasize, that with extreme wire bias, you often get a very favorable cut that's almost larger than the burr that you were using to begin with.
Yeah.
And that's because it was embedded in the plaque completely and taking out all of that material. So I would agree exactly with my colleague that I think I'm done with atherectomy on the LAD. I think I would double wire and balloon up. Of course, it's always, there's some degree of inaccuracy with evaluating this angiographically, but I don't see quite the same degree of calcium in the diagonal. And it may be a deep calcium, so that just ballooning in those segments plus minus IVL may be adequate.
I might consider OCT here just to see how much you've broken it up and what the degree of calcification is.
Yeah, the diagonal is a pretty big vessel and big
Yeah.
chunk of calcium nodule there. I think you have to modify that too. Otherwise, you're not going to get luminal gain in the diagonal.
Balloon.
So what will we do?
Jason.
So I know there's a discussion, we have to do OCT, but we already opened the IVUS, right?
Yeah.
We have the IVUS.
Yeah, so
The question is, what do we do with the diagonal? So I'm going to wire the diag.
yeah,
So
another
I would
option
wire
is-
the diag. I would think about maybe even seeing if you could IVUS both of these vessels now and think about what's next. Whether you have to do some more modification in the diag before you start dilating in the LAD. I don't know. What is Dr. Devori is here, Dr. Sharma. Which one of you want to tell us what you would do? Sanjeev.
Yeah, I would like to have a diagonal and then do the ballooning or a cutting balloon and see
Oh,
the.
you were thinking about cutting balloon
Yeah,
in the.
if there is no dissection, then make it a provisional, a ready stand, and then do kissing. And subsequently, you can do kissing with
Where's
the
the
DCB.
imaging? You want imaging or no?
Yeah, imaging first to the LED.
Okay, first to the LAD.
You
Okay.
always want
So other
imaging,
option
but
is to use the same wire,
Some dye?
go into the diagonal, do a rotor run to the diagonal also using the same burr, and then switch over to the.
So Dr.
Stem.
Chandra is also suggesting you might want to just go flip it into the diagonal and do a burr into the diag, the same burr you have. I don't know. I kind of want to see what I'm doing. I want to look at it. I don't know. Anybody else?
I think
Dr.
the
Davouri?
I think the imaging in the LAD will tell us if there's any osteocalcium in the diagonal. Right, if there's osteocalcium,
You
then
like
maybe,
that side view too. You've been trained by Dr. Sharma. All right, let's see. Dr. Kinney, what do you want to do? You heard all of us.
So let's go back. Yeah, let us go back here. So you see that? LAD, I know we are not dissected. I think we're like John LaSala mentioned, we have done a good atherectomy with 1.25 balloon via the diagonal. Now, can we go back and do diagonal rota? Yes, I think that used to be once upon a time. But nowadays, since we have IVL, we will image both. And why don't we consider? Now, IVL may not go into the diagonal, but let's at least image and then make a decision. Maybe he's right that we may want to do rota of the diagonal itself. There's no dissection, so I think that is a possibility. So we're going to image both quickly.
All right.
I think
the
a
plan
1 to
should
5
be-
bear on the diagonal not going to be a mistake. You have calcium there for sure. It's seen here. So it's just going to help you to do the rest of the procedure. It's one more step, I know, but it's in trade of not giving 1.5 bear to the LAD, you can do 1.25 to the diagonal. It is a big diagonal, and you want to have a good result there. So I think the 1.25 bear will help.
But if you look at this view, looks like, when you puffed there, looks like you already put a stent in the LED. It's so big. So I think you gutted quite a bit. So it would be riskier to pull that wire and then go through a guttering flap. So I would
let's
look at
see
the
what the
image,
IVUS
what it
shows.
looks like.
Coming.
Can we put the IVUS in the main, thank you.
I think the atherectomy did such a nice job, the IVUS went right down.
This is almost a 4 vessel.
Come to left main. Stop it.
Yep.
Pullback speed was 4.
Switch the diag.
Looks like you have a very big
I
lumen.
show. Wow. So it's a level of the diag, like a 270 calcium. Like I
Be
see.
loud, Kiski, I can't hear. Loud, I can't hear.
I see.
You broke the calcium on the LED.
Yeah,
for
where are
sure.
you? I just at the level of the diag.
Yeah, this is the level of the diag. So
You
see
broke the
diag
wall
from
also.
11
Look at the
o'clock.
bad tear. That's a bad tear that goes
Yeah.
towards the adventitia, right near the calcium.
Yeah.
Yeah,
tells
I
you
see
no
the
more-
liver
yeah,
ablation.
no
It means the
upsizing.
ablated surface of the
Well,
calcium.
see if
That's
the
why
IVUS
1 to
goes
5
into
are.
the diag. That would be really helpful.
Yeah, that's where I'm going now. And that we can make a decision.
Yep.
But this is
That-
going to be most likely 2 stents procedure. So you really want to have good expansion. And so you have to push on
Again,
vessel
IVUS
preparation
is not
here.
going in.
Yeah. So
Go.
the question
Can you
is,
see anything?
It's not a tight part, but can we stop?
That's the LAD.
LED, no. I'm trying to get into the diag.
The diagonal's
No?
really tight. I don't
yeah,
think
that
it's-
diag is
Before the
pretty
diag.
tight.
Yeah, it's going to
So
need
it
a
looks like you might need to burr that diag.
or do a
but-
pre-dilatation.
Yeah.
Or you could use a cutting balloon.
Cutting balloon might not
Yeah,
get-
IVUS didn't go, cutting balloon
2.5
likely
cutter.
won't go.
2.5.
I would use a smaller balloon and IVL it after that.
Okay, then get us a 2.5. Okay.
Yeah, I'd
Just
get
give me a
an
2.5
NC
high
balloon
pressure
first and then
2.5
cut
high
it.
pressure balloon.
And then
Don't open
do
the
the
cutter.
IVL.
2515, high pressure.
Rota. Now hold on. Dr. Sharma has arrived here. He's saying go rota of the side branch.
You can always say, why not?
Okay.
But this is an excellent example of where atherectomy is mandatory, really. I mean, you're
2.0
not going to get
2.5
that
balloon.
kind of a start
Get
on
the fine
that
cross.
eccentric, heavily calcified LED without
You're
doing
the
an
rota
atherectomy.
bar, right?
Yeah.
Totally agree. The more you
Where's the
invest
No, that's why-
upfront,
If we
the
need to
better the
do
results will be
IVL, I
later.
think we should do the IVL subsequently in the main LED and do the rota of the diagonal and then treat it with the IVL to the main vessel and then maybe 1 or 2 stents.
Show me the IVUS of the LED.
Sure. So this is the level of the diag.
See, this is another way.
Calcium.
This is another way
And after
that
that, there is
imaging
also
is helpful.
constant audio.
This
The
is a
surface of
very
the nodule
complex
is shaved, but
bifurcation
still like a
from the definition criteria.
huge
This is
chunk
as
of calcium
complex
there.
as it gets. It's two-stent strategy, obviously. But
Come.
if you do IVL in this, we've seen that if you do main branch IVL, the fracture and stuff sometimes jails the diagonal so badly that
Come
you
back,
can
Benji.
actually shut it down. So you have to be very careful if you're just thinking that you may actually be shocking the osteum and sometimes fracture, so it'll be easier to cross. You actually can go the other way. And
It can go both
shut
ways.
the branch
Get the
down.
125 bar ready.
But this is where secondarily imaging is helpful because you couldn't pass the imaging catheter. You know you need to do something else.
Yeah, for sure. I mean, that's why,
Have the
once I saw
freedom
the
on the
imaging
side.
catheter, I would
Keyboard
just
is-
roto the diag, but let's see what's going on. What are you doing now? You're dilating the diag and then hopefully bringing in a IVL catheter? Is that
Changing
it?
to rota. Changing to rota.
No, once once we have decided do the rota of the diagonal, you don't dilate. You just go with the
Oh,
rota.
okay, you're going to do
The-
rota. I'm
also-
sorry. I
that's a
didn't
good
hear that.
spe-
I don't know.
yeah,
I
it's a
thought
good
that's what
move.
you were doing.
50-50.
That's
Where's the
good.
clip?
But you have to take the LED wire out.
So we have a rota. And then also other thing was, Dr. Sharma mentioned, do balloon of the LED. That's something I would not do because you do balloon and you dissect there. I think leave it alone for now because I have to take out the wire of the LED when I'm doing
Exactly.
rota of the side branch. So that's what we're going to do. So I would not touch it. So far it looks good, no touch technique. We will do the rota of the diag and then decide, okay? So this is the LED wire that has to come out completely. And let's quickly go to the,
So the imaging does at least reassure
Give me the
you that
125
the
bar.
LED is fairly stable so that you can afford to pull the
Yes.
wire and go after the side branch.
yes. This is a situation like, don't do it at home.
Yeah, don't try this
Yeah.
at home. Yeah,
Because more
exactly.
people will be scared to remove that wire from the LED because initial wiring was not easy.
Yeah, I
Okay,
think
now we will do
that's what I
125.
would be. I would have liked to secure that a little bit with some balloon or something, but
So even in this day and age, it goes to say that there are cases where we will have to do rota of both the main vessel and the side branch. Okay, 125 again. So once we do the 125, then we will wire. At that time, what the Kiski, based on the thing, you're saying there's a nodule after the diagonal?
After that,
Reality.
there is a nodule, but the surface is shaved by the loader, but still like a huge chunk of nodule is there.
Dr. Keeney, thinking of
After this, I think we can just dilate and see, right? Rather than IVL of the main vessel.
yeah, I was
Leave
going to
that
ask
to,
what your
John, you
next
were saying
balloon.
something.
going to ask what
And
your
it's
next
so
steps are.
important to know
What
because
balloons and what's your
it's-
next step after that?
It's very hard to dilate
Test.
calcified nodules. And you really need to know
the
that. So I was
Looks
really
on.
telling you it's not going to be easy to expand the stent. This is the area where stents are coming back.
Okay.
So obviously, we've emphasized calcified nodules
I
on
got it.
other cases, which goes to tell you that they're difficult to deal with.
Okay, enough. Okay, good.
Anu, do you want to see how the flows in the
Wire
LED?
completely. No. Right now, quickly finish the diagonal. That's it. I think we're okay. No EKG changes. You see that wire pull back.
Where is on the-
so it's the same size, 1.25 burr going into the diagonal now. And then let's see how it all goes. Let's see if you're going to use the same technique to get it past that big rock of calcium there.
Yes, easier. I did all my 3 steps again. Okay, good.
And now she'll dynaglide it again, so you see she's taking the
Dynaglide.
tension off, so it doesn't
Ready?
jump.
Yes. Good. Okay, good. Ready? Now, this is also not a easy rota. You look at that.
How many RPMs?
Slow.
How many
Because
RPMs,
it's
Dr.
tight.
Keeney?
It's very tight.
About
there.
150.
150, okay. So low speed.
You see the angulation of the burr.
You see that? He was getting stuck.
Guide is getting set.
You saw that? It was stuck at the ostium?
Yes.
Wire was also coming
Your
back.
guide is very, okay, let's see now.
Yeah. See that? Yes.
Yeah. But we want you
Despite
to
going-
polish the ostium.
There it is.
And do you see drop in the RPM, Dr. Kinney?
No, no.
Okay, that's a good
There
sign.
you
That is
go,
a
you
nice
just
source.
did it.
You see that?
Yeah,
Yeah.
we
No, you're
saw
good.
that you just ablated it.
Okay,
yeah.
give me the wires quickly. Ready?
Wire
Coming
both
out.
Ready.
quickly.
Yes.
Again, for the
Yes,
audience,
exactly.
it's not unusual
And
sometimes
then
if you
I
don't
will
get through.
wire the.
If you don't get through it in
that's
2 or 3
sticky.
passes and you're getting stuck there, it's not unusual to go up on the RPMs.
You know, the fact there's no EKG changes, everything is going good. I don't think you disrupted anything in the LAD.
Again, it looks stable on the
Looks quite
on
stable
the IVUS. On the
everywhere,
IVUS.
which is good.
Okay.
Okay, get me the run through and the filter wire. Good.
So, Dr. Lasala, you're experienced rota operator. Would you always keep the wire, or you say, I don't care, I'm going to rewire anyway with the workhorse wire, saving all those exchanges wire, not expensive anymore? What do you do?
It's again, it's operator dependent. I just exchange out. I use a trapper or something like that and put.
Yeah.
I never like to give up. You know, I'm paranoid about losing wire position. I never like to give the wire up. So I put it down with a microcatheter and then use a trapper and put my favorite wire in.
I agree.
Never pay for the same real estate twice.
I guess.
Yeah, and I've seen,
It
one of
also-
the things I've seen in our lab is with Dr. Sharma and Kinney, they sometimes use the tracker depending, but sometimes they just use this wire. They leave the wire there and come right next to it with another wire, with a workhorse. So what are you doing in this case, Dr. Kinney?
No, I'm going to wire the LAD now and then the diag. Get the fielder ready.
I mean, there's a secondary benefit to coming down with the second wire and keeping the rotoblader wire in position is obviously it helps deliver subsequent things as well.
Yeah, I usually do that too. I leave the atherectomy wire, whether it's Vipa or this, along, and then a wire alongside with a
She got
workhorse.
the LAD
And then
already.
the balloon, actually, you use it at poor man's cutting balloon too, so it actually allows you to yield also.
Well done, Dr. Kinney.
Okay, now let's take a picture. Now let's take a picture. Okay, ready?
Yeah.
Okay,
Looking
everything is
good.
there.
Much nicer, yep.
Looking good. I think at this point,
So
you
now
just
let me
dilate
take a-
and stent, no? Or do you want to still
I think
Yes,
ballooning
I
is
think
okay
so.
now. You can do ballooning now.
You gave the 2.5, right? High pressure balloon we wanted. We didn't open the cutting balloon.
It's
So I'll
really,
wire the diag.
this is a key point is that just because it looks great on atherectomy, seldom do I go right to a stent. I mean, I always feel like it still needs more
No,
prep,
you
more
need to
prep work.
dilate here.
Now, you got a good lumen, so you could use an NC balloon and go up to higher pressures and make sure that you're going to have fuller,
Yes.
fuller
So
expansion.
we have a NC a balloon ready. 3.0, right? You have? Think out of 3.5. So
Would
we'll
you-
wire the diag, balloon it.
Yeah, wire the diagonal, it's always helpful.
And then we pre-dilate.
Are you using 7 French here, or 8 French, or 6 French?
Yeah, 7 French.
7 French.
We have a
yeah.
7 French, some die. Yeah.
Yeah, we do the same. On those lesions, you go high French size. I know the Japanese like to use smaller ones, but
What technique would you use here? Maybe good for discussion. Is it
For what one?
mini crush?
Yeah, we like mini crush. Is that right there? And when we went LAO, we were able to wire there.
And go Leo.
Go LAO. I usually never like to change.
this is why it was helpful to keep the rotor wire.
There seems to be a little bit of a plaque there blocking your entry into the
You're
diagonal.
going
Yes,
into a
yes.
shelf of the plaque.
You know, just as talking about other methods, if you don't want to exchange out, you could put a dual lumen catheter down there and put 2
And use micro.
track over that and put your other wire.
You got
Okay,
it.
good, go.
2.5 balloon.
Yes.
We do
2.5
should
balloon.
get it, but just for
I
discussion purposes.
whenever I'm with the fellows, I tell them pick one view and keep working on one view. But here, somehow, I think we could not get into the diag, needed LAO.
2.5 balloon.
No, we go with LAD first. What do you have, 3020 or 15?
3020.
Okay, so we are going to 30 high pressure. We'll go up to 2022 atmosphere, see how it looks.
Oh, there he is.
Dr. Sharma, he's behind me. Can you put him on?
Hello, Dr. Sharma. Hello, Dr. Sharma. We were looking for you in the other lab. Okay.
The man is mercurial. You can't keep up with him.
Okay. What did you get, Dr. Kinney? You opened the...
No, we dilated. You look at here. We dilated, looking so good. I think it's just time to stent it.
No, what I
Okay.
wanted to do, that see how the diagonal opens up. I think this whole case was the diagonal.
Yes, yes.
And that's the key. So how it opens up, then we go, we are ready actually. We are ready for a long time.
I know. I
But I think
know.
this is rather than, no, our goal is, no, I'll tell you what, we always decided that we want to go to all the steps to teach our audience there rather than just show and tell. So
Okay.
step by step, and in this particular case, a lot of step points. Now, once it is open nicely, you see the good angiogram, we are ready there.
So this pressure, we are going 22. Okay, so and also look at the cine. Nice expansion.
What size the balloon is?
Is it 2.5 balloon?
2.5. Yes, 2.5.
Yeah, looks like good expansion.
Really good expansion.
Okay, take a
So
picture.
you rotated both of them
And
and
if
with
everybody-
excellence expansion now?
Go.
Looks
Very
very
nice.
Yes.
You're done.
Okay.
You can go provisional
Now he's
now.
going. So I think the learning point in this case for the side branch, right? Yeah, could we have done IVL? There was a
Now we
question.
can go for
After
provisional.
Now,
point.
how do you
Provisional with the
Yes,
DCM
we could have done.
Flush on.
Yeah, we're not doing it. We do the case
Excellent.
presentation.
So,
Okay.
Okay.
We are
Dr.
ready
Sharma,
now?
are you ready? Let's
So
go
we'll
to
do
Dr.
2.5,
Sharma. We'll
15,
come back to see the
side
stent.
branch,
Fully ready.
3.5.
Yeah.
Dr. Sharma,
33.
Right?
So we can keep it a
we don't
provisional.
see you yet. We're still seeing Dr. Kinney.
Okay, how are we doing now? Can we see? Close the flush for the time being.
Not yet.
Okay, we
Can you see us? Yeah.
we still see Dr.
And
Kinney.
here?
Can we please go to Dr. Sharma's lab?